looking forward to this for some time. I'm gonna, just because not everybody's very familiar, while we wait for the last few people to log in here, just gonna give you a couple of items about Respicardia, if you wanna go ahead. So Respicardia was founded in 2006, and it is dedicated to improving the lives of patients using transvenous neurostimulation. Our first and sort of flagship therapy is, excuse me, the remedē system, which is transvenous phrenic nerve stimulation for the treatment of central sleep apnea. If you want to know more, I think it's on the next slide here, we do host a monthly webinar that's about the therapy where I go into quite a bit of the data. And there's a link in the chat to sign up for that. This is the last of a series of webinars that we've done, but if you'd like to be on the email list for future webinars like this, please type your email in the chat and we'll add you to that list. And now, excuse me, no COVID, but nonetheless, let's take a poll here real quick to see who we have on tonight. Let's see, and Jody, you want to pull up that poll? This will just give our speakers a little bit better idea of who all they're talking to this evening. Very good. All right. So with that, I would like to introduce our two fabulous speakers here. First, we're going to hear from Dr. Dupuy-McCauley, who's a Senior Associate Consultant of Pulmonary and Critical Care Medicine at sleep medicine at the Mayo Clinic. We're very excited to hear her talk about classification. And then, as many of you know, Dr. Tim Morgenthaler is the Vice Chair of Mayo Clinic Quality and Affordability and the Co-Director for the Center of Sleep Medicine, Pulmonary Critical Care and Sleep Medicine at the Mayo Clinic. And with that, I will hand things over to Dr. Dupuy-McCauley. Thank you so much for being here today.
Hello. Thank you, Dr. Germany and Jody and everybody at Respicardia for having Dr. Morgenthaler and I today. I'm very happy to be talking to you all. We're going to discuss identifying and treating the predominantly central sleep apnea patient today. Let me just get the slide to go here. Okay, there we go. All right, so I'm going to start off by talking about the evidence, methods, and existing clinical experience regarding classifying hypopneas. Then I'm going to talk about the existing treatments for patients with central sleep apnea. And then my colleague, Dr. Morgenthaler, is going to be talking about phrenic nerve stimulation and how to incorporate that into clinical practice. So, the reason that I'm going to talk about hypopneas is that last year I did some research about the classification of hypopneas as being obstructive or central, and through that project I learned all about the history and the various controversies surrounding the topic. It's a little known fact that hypopneas are very, very controversial. And classifying hypopneas, I guess I would sum up as being a work in progress, but I'm going to share with you some of the things that I learned about them through my research and hopefully shed some light on this issue. So as you all probably know, there are two main categories of sleep disordered breathing. The treatment for central sleep apnea and the treatment for obstructive sleep apnea can be quite different. So it's important to discover what the underlying physiology is of the sleep-related breathing disorder so that we can treat patients very effectively and swiftly in many cases. So why are we talking about hypopneas specifically? Well, apneas and hypopneas are the two important disordered breathing events that we base the classification of sleep disordered breathing upon when defining the AHI. And both of these events are given equal weight in the classification of a sleep-related breathing disorder. And both apneas and hypopneas can be central or obstructive in nature. But with apneas, there's very little controversy on how to classify them. And with hypopneas, it is not quite that simple. The key to classifying a respiratory event lies in determination of respiratory effort during the event. For apneas, it's fairly easy because all that we have to do is look at the thoraco-abdominal bands, and if there's persistent respiratory effort throughout the breathing pause, then we know it's obstructive, and if there's no respiratory effort, then it is central. So when you're looking at a polysomnogram, you see no airflow, persistent effort, bam, that's an obstructive event. And then no airflow, no effort, that is central. It's pretty straightforward and pretty easy. But with hypopneas, they are a little bit trickier because there's not a lot of agreement on how, why, or if we should be classifying them. And even the definition of what a hypopnea is has been changing since it was discovered in 1979. And I guess a persisting sign that we have not been able to come together on the details of this is the fact that we have two definitions for hypopneas to this day. One of them is the recommended definition, which is a 30% reduction in airflow with 10 seconds in length and a 3% oxygen desaturation or an arousal. And then we have an acceptable definition, which is what CMS uses, which is a 30% reduction in airflow that lasts 10 seconds and is associated with a 4% oxygen desaturation. But before we go any further in talking about this, I think it's important to ask the question, why, and do we even need to classify hypopneas? I'm going to argue that we do, and the reason is that some patients, you do a polysomnogram and they have a bunch of obstructive apneas, and so you know they have obstructive sleep apnea. Some people have a bunch of central apneas and you know that they have central sleep apnea. But then we've all seen those people who have a polysomnogram and they have an AHI of 50, but there's like one apnea in the whole polysomnogram and the rest hypopneas. And so what do you do then? How do you really know what the underlying sleep-related breathing disorder is? And, you know, sometimes we don't get an optimal titration where we eliminate all of the respiratory events. And so, you know, say you're going along in a titration with CPAP and you have, you know, residual AHI, you're at a CPAP pressure of 12, the patient wakes up, the study is over. And how do you know, are these hypopneas obstructive and it's just that you didn't get high enough in the pressure, or are they really central and the patient really needs something like an ASV or some other alternative treatment for central sleep apnea? And, you know, this can be a problem, like I mentioned, in treatment emergent central sleep apnea. In heart failure, that's another situation where the lines are often blurred between obstructive and central. You know, we classically think of central sleep apnea being very closely tied to heart failure, but heart failure does not exist in a vacuum. These people have a lot of other comorbidities and can be overweight and can have obstruction and central all at the same time. And so sometimes it's hard to determine, you know, which is really predominating obstructive or central disease. And then underlying all of this is reimbursement issues, because, you know, if you don't document things right, then you're not going to get the reimbursement, or the patient's not going to get the reimbursement for their insurance company that they need for the proper device. And, you know, unless you comment on the nature of all these hypopneas at the time of sleep study, then sometimes it's hard to go back and review that polysomnogram and really discover in hindsight what was truly going on. So we've established some useful scenarios in which you might want to classify hypopneas, but you can't just look at the respiratory bands like you would with an apnea. Respiratory bands and a variety of other technical methods have been used to try to distinguish respiratory effort during a hypopnea and have been largely unsuccessful so far. And here are some of these unsuccessful methods. So this is a piezo sensor, this is strain gauges, this is a CO2 sensor, and this is a thermal sensor. And all of those have been tried and found to be unreliable and inaccurate. In 2007, the American Academy of Sleep Medicine did say that esophageal pressure is the gold standard for measurement of respiratory events, but this has fallen out of favor as the gold standard for measuring respiratory effort because, as you can imagine, patients tend not to like an esophageal balloon when they're trying to sleep at night. And then, you know, another thing that I think is important to acknowledge too is that esophageal pressure is not infallible and there can be problems with signal quality. And there's also an element of subjectivity because the signal has to be interpreted by a human. And so, you know, while it is the gold standard and probably, you know, the best thing that we have or had at the time that it was being used, it's just still not perfect. In 2012, the American Academy of Sleep Medicine was still saying that esophageal pressure was the gold standard for detection of respiratory effort, but they sort of gave up the dream that this was going to be a widely used technique. They came out and recognized that it's not really used very often due to patient discomfort. And at that time, they made classification of hypopneas optional because they said, well, you know, you don't really need to do this in many patients, which is true. But they essentially just said that you can if you feel like it, but it should not be a requirement. And with that publication, they did come forth with a set of visual criteria that you could use to classify hypopneas if you wished to do so. If you read the document that accompanies this decision, you can tell that there were a lot of differences of opinion. You know, they talked a lot about what should not be used to measure respiratory effort. And then, you know, at the end of it, they kind of gave this visual criteria, but it hasn't really been validated. And, you know, it was just kind of a light suggestion, I guess. So they suggested classifying hypopneas as obstructive if there is snoring during event, if there is flattening of the inspiratory portion of the nasal pressure transducer or PAP device flow compared to baseline, or if there is thoraco-abdominal paradox during the event, but not during pre-breathing. And then they said, you know, if none of these three criteria are met, then you should classify the event as central. So as I mentioned, the visual criteria has not been validated, but there is a small body of work about other methods of non-invasive classification of hypopneas. And here are what I felt were the most significant manuscripts that I could find. So we have Argod, who and his colleagues who talked about pulse transit time. Morgenstern looked at machine learning, and they were using signals derived from an esophageal pressure signal. Mooney and his colleagues talked about inspiratory time and visual assessment of flow limitation. Then Randrath proposed a different visual algorithm, and Barry and his colleagues used chest wall surface EMG and inspiratory flattening of the PAP signal. And, you know, all of these methods, when you look at the statistics, are, you know, they have some sensitivity and some specificity and some accuracy, but it's really different to compare the results, you know, number to number, because there's so much heterogeneity in the way that these studies were done. If you'll notice, you know, in the definition of hypopnea, I had to devote a separate category to that because everyone was using just a cornucopia of hypopnea definitions. And then the other issue is that when you talk about a gold standard of measuring respiratory effort, everyone was kind of using a different gold standard measurement. So some people used esophageal pressure, but as you can see, Barry and his colleagues, they used the AASM visual criteria, which I thought was an interesting move since we don't really know how accurate that is in itself. So, you know, people are looking at this, but I don't think we're quite there yet, just because of how many differences there are between studies. And so this brings us to the research project that I did that I'm just going to talk briefly about. We wanted to look at the visual ways of classifying hypopneas, just with the idea that no one's really using esophageal pressure. We just need to let it go and move on. And we wanted just a very accessible and easy to use method of determining whether a hypopnea was obstructive or central. So we compared the American Academy of Sleep Medicine criteria with this Randorath algorithm. The Randorath algorithm has a few more criteria of just surrounding termination of the event, when the arousal occurs, and the stage of sleep from which it occurs. And we compared them and evaluated them for clinical use. Of course, we also, went our own way with the gold standard. So we committed the same sin as the rest of the people in the literature surrounding this topic. But we created a bank of 100 hypopneas. We took 50 hypopneas from a cohort of patients who were very classic obstructive sleep apnea patients. So, overweight, all obstructive events on their polysomnograms. And we pulled hypopneas from them and presumed that they were obstructive hypopneas. And then we did the same thing with the central cohort of patients. So people who were not obese, some of them had heart failure, some had opioid use, some had primary central sleep apnea. And they had to have a very low obstructive apnea index or none. And we pulled hypopneas from their sleep studies and presumed them to be central. Then we made these tests and we handed them to 2 teams of raters. And each team scored with one method first, and then we had a 2-week washout period, and then they scored the same set of hypopneas with the other method. And we had, similar accuracy to the other methods that have been studied before. It was about 67% on average for both the ASM and the Randorath method. One was not better than the other, and it didn't matter whether people scored with one first versus the other first. It was very consistent. And we also calculated the sensitivity and specificity. Both methods were very sensitive for telling when an event was obstructive, and they were both specific when they were determining whether an event was central or not. So, the big question is, how do we know if any of this is acceptable? And that is really a hard question to answer. Our conclusion in this project was something along the line of, if we can't be very accurate in measurement of hypopneas, can we at least establish some sort of consistency? Because what we learned is that if we're ever going to make any progress, then we need to pick some sort of a definition of hypopnea, choose a gold standard by which to compare accuracy to, and then create a body of work that can be compared with each other and built upon, so that we can work toward getting a more accurate and precise way of classifying hypopneas, and then hopefully get a better grasp on the nature of people's sleep-related breathing disorders. And so, we also thought maybe there are some phenotypes here that we're not even fully aware of. But of course, that would only be discovered through additional research. So anyway, that brings me to my conclusion of the hypopnea portion of the presentation. And now I'm going to talk about the treatments that we know of currently for central sleep apnea. So, treatment for central sleep apnea might vary depending on the nature of the central sleep apnea. There are several different subtypes of central sleep apnea. For today's conversation, I'm going to be focusing on the type that's associated with heart failure because it's the most common type of central sleep apnea. Patients might have a preserved ejection fraction or a reduced ejection fraction when they have central sleep apnea and heart failure. And it's typically associated with a respiratory cycle that's a little bit longer, about 40 seconds in length. The first study I wanted to talk to you about is the CAN-PAP trial. And so this study looked at the use of CPAP for the treatment of obstructive sleep apnea in patients with heart failure. They had to have an AHI of at least 15 an hour, and the participants had to have an ejection fraction of 40% or less. It was 258 patients total, 130 in the control group and 128 in the CPAP group. And they followed the patients for 24 months. In the CPAP treated group, the patients had their AHI reduced by 21 in the CPAP treatment group and by an average of 2 in the control group. And they found that CPAP for central sleep apnea increased the mean and minimum oxygen saturation a little bit. There was a little bit of increase in the left ventricular function. There was a reduction in plasma norepinephrine levels, increased 6-minute walk, and they found that these results were sustained at 2 years. So sounds pretty good. They found, though, that there was no change in atrial natriuretic peptide, which, you know, okay. But also, there was no difference in transplant-free survival, hospitalization, or quality of life. One important thing that I wanted to mention about this study that might affect its generalizability is the fact that they titrated these people over a period of a few nights and titrated mostly to patient comfort, not necessarily to the treatment of the central sleep apnea. And so some patients were left with their central sleep apnea suboptimally treated. And there was a post hoc analysis of this study looking at patients who had their AHI suppressed to a level of less than 15 an hour versus patients who they were on treatment with CPAP, but their AHI was not suppressed to that level. It was 57 versus 43 patients, so a little over half of them had their AHI less than 15 an hour. And they found that in this group of people who had central sleep apnea with an AHI of less than 15 an hour on CPAP, it did increase their transplant-free survival, and they showed better increase in left ventricular function. And so this might just reinforce the idea that there is some merit to treating central sleep apnea as far as survival is concerned and the heart function. So that's really the best study that I've found for CPAP in central sleep apnea. Another treatment that we sometimes use is supplemental oxygen. This is indicated for patients with hypoxemia during sleep. Of course, they have to meet certain criteria to get this paid for by insurance. There are no long-term large studies about oxygen for central sleep apnea, and we don't have any data on mortality either. Patients seem to respond better to this therapy if the baseline AHI is lower and if there is less hypoxemia, which I think is somewhat counterintuitive. But I also wanted to point out that the largest study to date was 36 people. And in that study, the AHI decreased from 49 an hour to 29 an hour. So, you know, oxygen is something that you can try. I've actually seen it work really well in certain patients and not at all in others. You know, we don't have any data about mortality, so you can't really counsel patients on that benefit. But, you know, again, it's something to put in the toolbox and something to consider. Now getting into more PAP modalities, we come to ASV. So ASV is a bi-level device, and you stabilize the airway with EPAP, or the expiratory pressure. And then there's a variable inspiratory pressure that bases the level of pressure delivered on either a 3 or 4 minute window of the patient's previous respiratory cycle. ASV improves the ejection fraction by about 6% in a meta-analysis that I found, and it was shown to decrease the AHI by 31. I've seen some literature that suggests that it might be better than CPAP in controlling central breathing events during sleep. And there's also some data to suggest that compliance may be better with the ASV over CPAP. But ASV is not the perfect treatment that we would want it to be. Of course, the Serv Hf Trial came out in 2015. In that trial, they looked at over 1,000 people with an AHI of greater than 15 and symptomatic heart failure with an ejection fraction of 45% or less. And they found that the ASV did a great job in controlling the central sleep apnea, but it raised all-cause mortality. And so, you know, this is a really difficult situation sometimes when you have a patient with a low ejection fraction who, you know, CPAP and oxygen doesn't work for. You can't use ASV, unfortunately. The mechanism for why this happens is not known. Some people think that these very high IPAPs increase intrathoracic pressure and thereby decrease the cardiac output or stroke volume. Some people think that maybe Cheyne-Stokes respiration is a protective mechanism, and so by taking that away, you're taking away a mortality benefit, but we haven't fully worked out the cause for this yet. For BiPAP-S and bilevel ST, we don't have a lot of evidence for those in the setting of central sleep apnea. There's only very small studies. And I think using these are a little bit controversial too, because if you are a believer that it's truly the increased IPAP and increased intrathoracic pressures that are causing this increase in mortality, then if you're using a bilevel ST, that's really going to do the same thing. And so I have talked to people who are reluctant to use bilevel ST, even though we don't have any study saying that it increases mortality. And then same thing with removing the potentially maybe protective effect of Cheyne-Stokes respiration. Of course, you're going to do that same thing with a bilevel ST. So is it really better than ASB? I don't know. I don't think that we know that. And then I put this in here just for the sake, because it exists. Pharmacologic therapy does exist for central sleep apnea. Acetazolamide is primarily what people might use. We don't have any studies of long-term effects. People can have side effects on this medication. It has been shown to reduce AHI and daytime sleepiness in central sleep apnea, but it's not something that we use commonly. But I did want to include it just for completeness sake. And so that brings me to the final treatment that we have for central sleep apnea, which is phrenic nerve stimulation. And with that, I am going to turn it over to my colleague, Dr. Tim Morgenthaler, and thank you everybody very much.
Well, thank you, Dr. Dupuy. Can you all hear me all right?
Yes, you sound great. Thank you.
Very good. Very good. So I'm going to just kind of start my talk with a couple caveats. The first is to say that my talk is going to be a little science light and practice heavy. So I've kind of put this picture here to tell you a couple things. The unvarnished wood on the left is to remind me to tell you that I'm going to tell you the unvarnished truth here. I'm going to give you the story of implementing phrenic nerve stimulation that's not terribly glossed over. I'm going to tell you the good, the bad, the ugly, and so forth. And the picture on the right of this is probably strategically not very smart to show at dinner time, but in terms of thinking about how to start bringing phrenic nerve stimulation into your practice, I do think it's a bit like creating a good meal. You need to have the right ingredients, you need to have a good recipe, you need to have meal planning, and then you can expect a good result. So I'm going to start with that kind of as a background, and I'm going to start with then, what about the best ingredients? Phrenic nerve stimulation is really, I think, ideally suited to this population of central sleep apnea patients that we don't have these other mechanisms for. And so in particular, I think it's one of the best options possibly for patients who have central sleep apnea, Cheyne-Stokes respiration associated with reduced ejection fraction. As Dr. Dupuy already indicated, we don't really have a tremendously successful positive airway pressure treatment for those patients. We try it, but oftentimes it's not successful to try CPAP. ASV, I think we're quite skittish about that. BiPAP-ST, I personally don't tend to use that in this patient population for all the reasons that Dr. Dupuy-McCauley already pointed out. So I think that's a really great ingredient if you're thinking of starting this program, is to find those patients. I would also say that central sleep apnea of any sort, regardless of their ejection fraction, who don't really tolerate positive airway pressure therapy and won't or can't respond to oxygen, this is another option that we have where I don't think we really had many options before. So, having said that, I think we do need to realize that those patients who have complex sleep apnea or treatment emergent central sleep apnea, the diaphragmatic or the phrenic nerve stimulation will not really deal with the obstructive component. And so if that's an important component at the beginning of their treatment, you have to anticipate you may still have some problems. And I'll actually give a case, something like that in a moment. And the other thing is, I think we need to be, particularly early on as you're starting to implement this program, I think you need to keep fairly tight definitions of what your patients have. Because this is not an easy thing to start up. That's just my opinion from experience, but I think it can be very rewarding. So, where are you going to get these great ingredients? I live in the state of Minnesota. Our air quality looks just like that. Sorry for those of you who live out west. And actually, that's my garden over the weekend on the right, and that's a basket of produce we brought in. So we're getting those fresh ingredients. Where are you going to get your fresh ingredients for your program? Well, basically, these patients are most often patients who have congestive heart failure. And you all know that, about a third of patients with congestive heart failure that have been referred to sleep centers in many studies have moderate to severe CSA, and about 21% in another series that was from a cardiology clinic, they had moderate to severe CSA. So, I think really the garden that you have to go cultivate is with your cardiologist or whoever's monitoring or managing patients with congestive heart failure. CSA is often seen post-stroke as well, or in programs, that you may have a stable methadone maintenance program or a very strong pain management program. You may find a lot of opioid-related central sleep apnea. And then there's always an ample supply of people with treatment-emergent central sleep apnea. But again, I'm personally not sure that that's the very best patient population for this particular technology. So, if you hone in a little bit on these patients with heart failure and reduced ejection fraction who also have central sleep apnea, this is sort of my, I can't get quite as technical as Dr. Dupuy-McCauley, so I've kind of simplified it here. CPAP, if you use it, a little less than a third may correct their AHI. There's at least no harm in any of the studies. There may be a mortality benefit. That was a post hoc analysis, so we always have to worry about taking those at their face value and realize this was not a prospective trial, and we can get in trouble with that. But at least it doesn't seem that CPAP is harmful. So I do always try CPAP or ensure that CPAP has been tried, because sometimes you get lucky and it's effective, and now you have a very low-tech solution for the patient if they can tolerate that. Oxygen, I think my experience and Dr. Dupuy-McCauley's are parallel. I mean, well, first of all, I think we all can identify with the pain of the fact that many of these patients don't qualify for oxygen. Even if it might benefit them, we may have a hard time from a practical point of view getting that therapy for them. I don't think there's any evidence for harm. The benefits that are seen are all on, for the most part, have been on short-term intermediary markers like ejection fraction or epinephrine levels. There may be a mortality benefit. It's worth a try. I would say if you try oxygen, and it's probably worthwhile to try it if you think you can actually get the patient covered for it. I think a common mistake that I see is people are thinking like COPD, and so they're giving these patients 1 and 2 liters per minute of oxygen to try to, eke them up over the 90% level. And in reality, what you're really trying to do is you're trying to fool their feedback mechanisms, and they're going to need higher oxygen flows, often, 2 to 4 liters per minute, even though they're not hypoxic. You're really trying to drive them a little bit supraoxic, if I think that's the right adjective. BiPAP-S is in the literature. I've never seen a patient benefit from it who has, Cheyne-Stokes respiration. In fact, usually, to me, it seems like it's likely that they'll make them worse. ASV, again, depending on how low their ejection fraction is, it's very effective at reducing their AHI. We've done quite a number of studies here at Mayo Clinic, and about 85% of patients in whom we use an ASV who have central sleep apnea, we will succeed in controlling their AHI. But then there's that darn Serv Hf trial that shows that this may not be the best for patients with an EF less than 45%. So I think, when you're all done working through that, the transvenous diaphragmatic or phrenic nerve stimulation is really our potential hope for the miserable, I'll say. So if you've got the right ingredients, now you need a group of people to cook with. And what I'm really trying to put here is this is a big endeavor in teamwork and collaboration, because now maybe some of you in the audience were cardiologists, but most of us are sleep medicine physicians or pulmonologists or neurologists, and we're not doing the technology to insert these devices. So we need to somehow make our efforts come together. So, first of all, just in terms of, how do you improve access for sleep care of cardiac patients? Because again, I think most of the patients for this technology you're going to find come from your cardiology pool of patients. If you haven't already done this in your medical center, it's really worthwhile to sit down with a group of cardiologists who work in the hospital admitting patients with heart failure or who have a heart failure clinic and develop protocols that enhance the recognition of sleep disordered breathing. This is not only for central sleep apnea. You know that about 30% of those patients also have obstructive sleep apnea that's often unrecognized or untreated. And I think we can all feel comfortable that we need to find and help these patients. This could range from either implementation of questionnaires or implementation of overnight oximetry as a screening tool. These are all pretty successful ways to aid the cardiologist in finding those patients who have sleep disordered breathing. The second thing's very, just practical. How can you smooth access for those referrals from the cardiologist? You're dealing with what I would call a high opportunity population, by which I mean there's just a high prevalence of disease in those patients. So what can you do? Think through what can you do to smooth the access for those referral, because you're going to have an opportunity to treat more patients and more patients will benefit from treatment. Some centers have experience with actually embedding sleep medicine specialists or nurse practitioners who are part of a sleep medicine practice right in with the cardiologist, because this is such a rich environment of patients who often have sleep disordered breathing. In our system, we don't currently have sleep medicine physicians embedded in the cardiology practice, but we do have an inpatient sleep consult service, and we're very frequently called on to see patients who are admitted to the hospital with heart failure, and our cardiologists, as a natural part of what they do, they tend to get an overnight oximetry, and then you can see the abnormalities that you would expect to see, and then that engenders a handshake between our service and their service, and ultimately we can connect and help those patients. There's also a certain amount of expertise that you may need to invest in dealing and caring for these patients. They do have some unique needs, and anytime that you can really understand their needs and understand the rest of their health system that cares for them, it's going to really enhance your practice, and more importantly, it's going to enhance care of those patients. And then as we go forward here, you'll see, we need to make sure that our laboratories and sleep technologists are capable of really implementing all of those treatment methodologies that I just showed you. Are they familiar with one or preferably both kinds of adaptive servo-ventilator devices? Are they familiar with oxygen titration for central sleep apnea? Are they familiar with how to titrate CPAP for central sleep apnea? So, you may have to sit down and really go over that and write down protocols and so forth. You may find that that's very helpful in how to improve access and the care of cardiac patients. So once you've kind of established you've got the infrastructure, you've got the right ingredients, you've got the right people to work with, it's time for a planning meeting. This is, in our case, we sat down with the practice chairs from the Department of Cardiology and their operations managers, which are kind of like office managers if you want to think of them. And we sat down and said, okay, how are we actually going to do this? If a patient's interested in having this particular therapy, they might contact Mayo Clinic. Where do we send them? How do we know where to connect with that patient? And how are we going to do that? So we first kind of became to an agreement about what the eligibility for the phrenic stimulation would be. And we agreed that we would really want to be looking for patients who have moderate to severe central sleep apnea. We'd like to have a sleep study that's current to at least within 12 months. The AHI greater than 15 is sort of redundant. We would really not want to start a deep evaluation of somebody whose AHI isn't at least comprised of 50% of central apnea. So maybe that will change as we start to implement some of Dr. Dupuy-McCauley's criteria for hypopneas. But for right now, to just make sure we're kind of staying somewhat pure in our phenotype, we look for those who have a central apnea index greater than 50%, relatively few obstructive apneas, and we don't want to get into the pediatric age group for this. There's some other FDA labelings and exclusions that are actually carried right on the labeling for the device, and so we just stuck with those. We wouldn't want to go off-label in an innovative implementation. So then we do this commonly when we implement any treatment protocol that requires a high level of collaboration, is we actually tend to make these kind of flow charts, and we keep those right on our Sleep Center page so that all of my colleagues can look at it. This might be something you don't see as often as obstructive sleep apnea. So how do we make sure that everybody approaches it the same way? And so we've kind of laid out these protocols, and we'll revisit them from time to time and update them as we learn. For us, I think the important, you don't have to memorize what's on these pages. For us, the important thing is we've decided that when a patient contacts Mayo Clinic and they're interested in this, they first come to sleep medicine, and we're going to take on the evaluation of those patients before we then refer to our proceduralist cardiology friends who would actually be responsible for implanting the device. So we really start the evaluation. We evaluate whether they're eligible. If they're not, we're going to go take care of their problem, but it's not going to be this way. And then I'll show you some other things that we think of as we start evaluating them. On the right, once the device is implanted, then begins a cycle on sort of a 6-week schedule, so that we tend to see them about 6 weeks after they've been implanted. During that 6 weeks, the device is not turned on. The device is acquiring data. The patient is healing. The electrode hopefully is becoming securely attached in the right places. And then we schedule a visit. Now that visit has to be coordinated it will take place in our Center for Sleep Medicine. It has to be coordinated with Respiratory engineers and with somebody from, many of our patients, or some of our patients, have also a pacemaker or an AICD, so we'll need to have someone from the pacemaker service be able to come by at the same time and make sure that we don't have any crosstalk as we then activate the device. So it's 6 weeks, assuming there's no new problems detected, we'll activate the device. And that activation is a empiric activation. I'll speak to that, but in essence, they have to take readings on exactly how the different leads, what the impedance is of each of the different leads in a variety of positions, and choose initial settings to start letting the device work. And so then we would send them out for 6 weeks, and over that 6 weeks there's a gradual turning on, if you will, of the device. The device sort of self-titrates it stronger and stronger, and then we see them back in 6 weeks again to see how things are going. That 6-week cycle will continue until we feel like we have the magic recipe, and at that point then we cut them loose to have a sleep study, because we want to make sure that not only do they feel good, and not only are the engineering's readings good, but they actually are good. And if everything is looking, straight away, then we would say, well, that's pretty optimized for now, and we have a few patients now that are into the routine follow-up mode of every 3 to 6 months. And to be very frank, I'm just learning this, so I'm working my way through what those visits will look like. But we don't anticipate that they'll be terribly involved unless new difficulties arise. Getting started it would be inappropriate to not at least discuss something that I'm sure you're all thinking about, and that is finances, for funding, turf. These can be issues. Now, Mayo Clinic is a multi-specialty, not-for-profit practice, but we sure don't aim to lose money. We don't aim to operate at a loss, because that will deteriorate our mission. Functionally, what we actually do, it's not that the cardiologists and the sleep medicine specialists are exactly the same, although we're all employed by one Mayo Clinic. We do keep separate financials by division or department, but we're very used to optimizing, not just on a per department basis, according to anything. We're very used to optimizing the care for the patient and then trying to make sure everything else works out. And so our leadership, as we were thinking of introducing this, and really with, I think, good advice from Respicardia, was, well, let's try a few first. Let's work out the kinks. Let's see how the finances work out. Make sure that our insurers in the local domain that we practice are willing to work with us here, and we'll work on things from there. So that's really how we started. We agreed up front that cardiology is certainly going to do and bill for all of the procedure-related aspects of this treatment strategy, and we will bill for all sleep E&M services and sleep studies as are clinically indicated. So everybody's kind of staying with doing what they do and what they know how to do. The programming and the device titration we decided will occur and be coordinated in the Center for Sleep Medicine because we actually have the room and we have sort of the right sets of expertise for that, and we'll borrow from cardiology when we need to for some of these checks. So that's just sort of some details that some of you might be wondering about that we thought were worth mentioning here. So let's say you kind of have had your planning sessions now. That's kind of the planning. You know, what do you, those are some things I think you really need to think about as you're considering whether to start this kind of project. So what are the considerations when the patient lands in your office? And, you know, I would say that, you know, one of the things that I've already said is, you know, your patient selection is going to be important. You really want to start this with some very clear, very good cases of central sleep apnea that need therapy, and that this is clearly the best therapy that you're going to be able to offer them if you believe the literature and how it works. You know, part of that will be really ensuring that you have confidence in their diagnosis. Many of these patients are referred with a diagnosis of central sleep apnea, and they're interested in this therapy. And, you know, you first need to really look carefully at everything and also consider that things change. That's why we had that, you know, at least 12 months prior polysomnogram. Things do change, you know, over the course of months, as you know. You'll also want to make sure that other sleep disorders are well addressed. It won't really make much impact on the patient if this particular problem is dealt with and they still have horrible restless legs and they can't sleep, for example. I mean, you all know, you know, many of you are sleep medicine physicians. The bulk of these patients have more than one sleep concern, if not more than one sleep disorder. One of the treatments that neither Dr. Dupuy-McCauley or myself said that's so important is treatment number one for central sleep apnea and congestive heart failure is make sure their heart failure is treated. And we didn't say that overtly. I think we all know that, we believe that, but we have to make sure that we've got the right diagnosis and that they're already being managed well for their heart failure, and there may be other underlying medical conditions that need taken care of. So then, you know, for me, this is just my personal thing. I really have to go through and feel comfortable that effective PAP or O2 therapy is really out of the question, either because it's been tried and doesn't work or because the patient really just can't tolerate it. For me, that's very helpful. And then, you know, do they need any further evaluation? Do they need a cardiac evaluation? Because it's been a while since they had that seen. So things to consider about. And then, you know, very importantly, these patients really need education about the whole process. What should they expect? What should they expect in terms of who's going to be part of the team and where are they going to go and why are they going to go there and why is it organized that way? If you were a patient, you would want that information, and so we want to make sure that they get that information.
Hey, Tim, can everybody else hear Dr. Morgenthaler?
Sorry. Can you hear me now? Are you able to hear me now, Jody? Okay, yeah. So what I was saying is, you know, we just got started about a year ago and COVID happened in the middle of this. So, you know, there may be people on this call, I'm perfectly aware, that have more experience in this than I do. So I'm just sharing our experience. There may be more experience. Our first patients came from 4 different states. That's kind of the nature of our practice. So I had Mr. Wisconsin, Mr. Iowa, Mr. South Dakota, and Mr. Minnesota. I'm just going to share a couple case studies that I think illustrate some of the points I talked about. So the first patient that I'm going to talk about came to my attention in April of 2019. That was the consult visit. This was a guy who'd had a long time of being sleepy. He'd been diagnosed 8 years previously with moderately severe obstructive sleep apnea. There's evidence in the chart that he really did try to use CPAP, but just found it miserable and did not find a lot of relief from it, even when he toughed it out. And so he abandoned that. He had recently experienced some chest pain and got admitted to a hospital elsewhere and was found to have heart failure. When I was first seeing him, I had only his history of this sleep study that he had done in another state at a smaller sleep facility that had really found that he had severe central sleep apnea. This patient had a very persistent advocate in the form of a spouse who was able to get me a copy of that sleep study in EDF format so that I could go ahead and review the raw data, which again, remember, I wanted to be confident, so this really helped my confidence level in this patient. He did have 117 apneas per hour, I'm sorry, total, with a resultant apnea index of 17.5, but 100 of those 117 were central. So he had moderately severe central sleep apnea. His echo had an ejection fraction of 22% with just generalized hypokinesis. At that time, we were just getting started. I had recently seen evidence that oxygen had been tried and really did not help. And so we were ramping up. He was miserable. We were working out some of the bugs and some of the things I just talked about. So actually, I started him on acetazolamide, starting at 125 milligrams nightly, and said to titrate up to 250 nightly according to his symptomatic response. And actually, he had some symptomatic response. His wife was a very persistent and accurate observer of his breathing, and she said, yeah, his breathing's actually a little better, but he still was not by any means feeling great. So he actually went a couple months later for his implantation consult, and they were really planning and ramping up to do that. But some things got in the way, and then he got all embroiled in 8 months of dealing with some significant shoulder pain. And this went back and forth with injections and so forth and so on. And ultimately, he had a shoulder surgery about 8 months after that. Now, do the math, and you realize that he's coming out of his, he's coming out of this surgery just kind of coming into COVID. So then there were some additional delays there. But finally, in 6/2020, we were able to go through with the procedure. We decided we would cover the costs if insurance never came through, and so he had his implantation in 6/2020. That meant his first activation visit was in 7/14. Now, usually there's only one activation visit, but in this particular gentleman, we had his activation visit. Everything seemed to go well, and when we sent him home, he really found the first nights at home quite intolerable. He was very anxious. He could really feel the diaphragm activating. It made him very jumpy, very uncomfortable. And so the device was turned off, and we arranged for a second visit to come in and try something a little different. So the second activation visit was really still activation because he'd only experienced like 2-3 nights of activation. And we started very, very gently. And then I just saw him back actually very recently, maybe that was last week, for his first what I would call titration assessment visit. And actually, he had a remarkably good symptomatic response. For one thing, this was the first time that I'd seen him that he drove himself here from another state. Every other time his wife had driven him. His wife sent me a very long, classic, epic in-basket message that extolled how much better he was feeling, that he could actually carry on conversations with his family. They noticed his fatigue was less. He was eating a bit more. I cautioned him against that. I'm showing you here PROMIS 10 scores. Now, I'm not used to seeing patients who have central sleep apnea be terribly sleepy. I already mentioned this man was sleepy, and he was less sleepy. His Epworth improved by about 30%. But I was most impressed by this. Now, I'm guessing that most of us here are not that used to using PROMIS 10 scores. PROMIS 10 is a sort of balanced quality of life score. PROMIS was the patient reported outcome data trove commissioned by the NIH, and just to kind of give you an interpretation, the T scores for the physical and the mental scores here. The T scores basically say that if you're at a T score of 50, you're at an average score for the population, and if you're at if you're 10 below that, that's 1 standard deviation below, and if you're 30, if you're down at 30, that's 2 standard deviations below the mean. So here's a guy who, back when we first implanted him, he was really back at 1.5 standard deviations below the mean for his physical and mental scores. And really, after just essentially 1 month of therapy, he'd really improved quite a bit. So I was very impressed with that. We'll be seeing him back. There were some very small adjustments made, and we'll be seeing him back in 6 weeks. And if we still have no new problems, we'll go ahead and do a sleep study. And that'll either be a type 3 home sleep apnea test or an in-lab polysomnogram, so that we can just sort of prove that this isn't just a placebo type of effect with regard to treatment of central sleep apnea. We want to make sure that we've really corrected some of the physiologic abnormalities as well. I have time to share one more quick one with you. This is a different patient. He was diagnosed with central sleep apnea elsewhere and failed PAP therapy since 2014. He came here very disgruntled. He had idiopathic central sleep apnea. He had AHI greater than 25. Most of those were centrals. And when they put him on CPAP, it was even worse. He had a normal EF. He did have some coronary artery disease and had some stents. He did not in any way, shape, or form wish to consider any kind of PAP therapy. I'll bet some of you have met some of these individuals. And therefore, we discussed the possibility of phrenic nerve stimulation, and he had the implantation and some improvement after titration. But wouldn't you know it, when I saw him back the second time, he had gained some weight. This might have been COVID weight, and he now had obstructive sleep apnea. So I actually had to put him on a CPAP. Now he was willing to consider it because he had some relief of his central sleep apnea. That was a little bit of a surprise to me. And what I have to show you here is just some segments of polysomnography that have been wed to the recordings from his device during polysomnography. So on the bottom, you're seeing typical respiratory tracings from what you might see in your sleep lab at night. Here's the rib and abdomen RIP. On the bottom, this is labeled PAP pressure, but please disregard that. This is really PAP flow on the bottom. And so, I think all of us would look here and say, well, these are central apneas recurring over and over again. The time scale here, this is 10:43 to 10:47, so this is like 2 minutes. And so, you can see he's having quite a lot of central apneas. Now, and he has CPAP on during this time, so we're not treating his central apnea with CPAP, that's for sure. And then what happens here, we've tuned the filters on the PSG leg tracing so that you can see the activation of the phrenic nerve. And so you see here this little salvo of activations with the resultant changes in the rib and abdomen and some flow. And this kind of matures a little bit as we go on to the next couple minutes, where now the device has turned on in earnest and is continuing. And I think you can kind of begin to see that, we have a quite normal respiratory pattern now over this time period. This is 10:48 to 10:53, so this is a little longer here. And you can see a pretty normal respiratory pattern with CPAP plus the remedē. And then, for those of you who are disbelievers, I painted out a whole bunch of minutes here, so here you go. So I just wanted to show you those. I think the real name of the game is coordination. You need to make sure you're coordinated with your cardiologist team. There does need to be at least for us, there has to be a high degree of coordination initially with Respicardia and their engineers. I think as you start this up, you're going to have to do some iteration. There's visits that you'll have to coordinate. There's polysomnogram nights that you might have to coordinate. Messaging is not inconsequential. When the patient leaves here, no matter how much education you've given them, are they going to call the cardiologist? Are they going to call the sleep medicine specialist? Are they going to call Respicardia? Who are they going to call, and how are we going to inform them of the right way to do that? So the other thing that I would say you need to keep in mind as you set this up is, where are you going to do this activity? We had kind of decided to do this activity in our sleep center. We tend to use our beds. Our sleep laboratory is immediately adjacent to our sleep clinic. And that actually makes it very convenient to have them lie down and do in different positions. So we're really simulating their bed rather than an exam table, but it can be done on an exam table. You just need to make sure they don't fall off, because that's very bad. And then, of course, if you're using your sleep center laboratory beds, especially now there's COVID considerations. So, how do we ensure that the rooms are cleaned in between use? We might have somebody who's coming in that night to use the room. And it also brought up for us, well, how many people can be in one room together at the same time and stay safe? Sometimes the best Respicardia team is 2 engineers, and I'm going to certainly want to be there, and I might be wanting to share with one of my colleagues what's going on so that we develop more and more expertise at our center. So pretty soon, if the patient wants to be there and they got a spouse or something, we're kind of too many people in the room. So just things to think through. And I've already mentioned insurance issues as something you may need to investigate. So I've taken time to discuss the ingredients and the chef team and the planning, and I hope with all that we can make a very good meal out of the whole thing and really serve our patients well. So that's what I had. I